Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hello, John.
Hello, Jay.
How you doing?
I'm good. How are you?
Oh, doing great.
How's the West Coast?
Hot and humid.
Hot
for a
and
change.
humid. Well, that's how it is every day here.
Yeah, that's true. Yeah. I guess I can appreciate the dry heat when we have it.
I just need to come out there and just see how humid it is out there.
Well, it was 64% today.
Okay.
Yeah. So I went out.
100% here. All right.
Yeah. Yeah. Well, I lived in Boston for 4 years going to dental school, so it's pretty humid up there in the summer.
All right. Yeah, I bet. All right.
Yeah. All right.
So we got a good show tonight. As always, there's always going to be new drugs approved. Never a dull moment there. And it seemed like just like yesterday, we were already doing PharmaDocs for last month.
Yeah.
And more new drugs out here to tell our fellow practitioners about. And
exactly. So we may as well get going.
Yeah, let's talk a little bit about our sponsors first, because without them, we can't do this, Jay.
Well, sure. I'd be happy to. So our first sponsor, who has been our sponsor for quite a while, is Iqirvo and their product Iqirvo RX, which is for electronic prescribing of prescriptions from any device, which is really convenient if a patient calls you when you're out of the office or when you're in the office and you need to send in a prescription. It makes it quick and easy and, of course, secure, and you've got a record of it. So Iqirvo RX is a product that, take a look at it. See if you're not already connected with your e-prescriptions, give them a look. And then Fortune Law Firm.
You got to love those guys, Jay, because they're all about asset protection, license protection, tax strategies. I mean, they're all about us. All right.
Yeah.
They're all about protecting not only our practice, but also our livelihood, especially if you have a negative outcome in your office due to a medical or sedation emergency. You're going to want these guys on your side.
Yeah.
Great guys.
Yeah. And they get you basically your assets and states set up so that it's protected, which is great. And then, of course, we have our home away from home, the Vesper Institute in Cincinnati, Ohio, where John and I
greatest IV
teach
sedation.
An IV sedation course. And, it's great, not just because it's me and John and Dr. Sayer, but the way that we set this up is we looked at all the other courses out there and looked at what was good, what was bad, and what was missing. And we think we put together a pretty comprehensive course that involves some online, some in-person didactic, skills stations for a full day, one-on-one IV sedation training with an IV sedation trained general dentist. So you're not going to the hospital and putting in an IV and just kind of standing there and looking around, watching around.
Great clinicals with them.
Yeah. And we also have follow-up. So once you've graduated, we help you to get your moderate sedation permit in your state. And we're always there for you. We have about a monthly kind of conference call or Zoom conference call where we all get together and talk about cases we've had and any issues, questions we had, and maybe throw in a little education while we're at it. So that's something you don't get with most other courses.
Well, with no other courses, Jay, only ours. Okay.
Yeah.
All right. Once you finish, you're never finished. You're part of Vesper Nation. All right. We want to see you succeed. We want you to be successful at this.
And then finally, Balanced Pharma, who is a company that John and I both are consult with, and they are developing a buffered local anesthetic carpule for dentistry that will basically, rather than injecting an acidic local anesthetic, it's going to be buffered, so less painful injection, and I think all our patients want that. And it also kicks in a little faster too, and more reliable. So balancepharma.com.
All right. Our first drug. Let's get on it, Jay. Let's talk about Rytelo.
Rytelo.
Like Nutella. Huh? No.
in, in Middlestat, which was approved back June 6th.
Yes.
And this is an oligonucleotide telomerase inhibitor
Woo.
that, tongue twister, that's indicated for treating
MDS.
myelodysplastic syndromes in adults who have anemia as part of their symptoms, and they're not candidates for erythropoiesis stimulating agents like Epigen.
Epigen.
Yeah.
Yep.
And so, for those of you not familiar with with the telomerase, what this basically is telomerase is an enzyme. It's a reverse transcriptase, actually, that is present in basically the zygotes and embryo. And it's like a cap, protective cap on the ends of the chromosomes that are involved with cell replication. And as the person grows older and older, these telomeres are degraded, which eventually may lead to some type of mutation in the chromosomes that makes them stop replicating. In cancer cells, a lot of cancer cells, they have the ability to produce telomerase so that these telomeres are protected. And that allows the cancer cells to replicate like crazy, like they're, brand new embryonic cells. And what happens, of course, in the myelodysplastic syndromes is that normal bone marrow cell lines, rather than producing normal red blood cells and normal white blood cells, are crowded out by all these abnormal cancerous cells that just keep on replicating.
Yes.
And what's nice about Rytelo is that it selectively kills the malignant stem cells, because mature somatic cells don't have the telomeres to mess with.
And Jay, talking about the telomeres, I mean, many people are going to hear about this, Jay, because of anti-aging products.
Mm-hmm.
Like you already said, it's involved, in the zygotes and in our embryos as well. Mm-hmm. But they've shown when telomeres are malfunctioning or aging, we're aging. And if we can rejuvenate or reverse that process on the telomeres, you can slow down aging in yourself. All right. And that's what functional medicine doctors are all about.
Yeah, that's what they're
not
working
only
on.
Your wellness, your well-being, but also your longevity. So
absolutely.
I encourage people to check out that about telomeres.
Yeah. Probably go to telomeres.com. There's probably something there. So again, this is just
telomeres.
Yeah. This is just a little illustration showing what's going on in myelodysplastic syndrome, where the normal bone marrow anatomy is basically obliterated by these cancerous red blood cells, white blood cells that are non-functional and continue to grow like wildfire.
And look at the family that comes from the blood stem cell. Mm-hmm. What all continues afterwards, whether it be the red blood cells, the platelets, the white blood cells, all mm-hmm. come from the stem cell.
Yeah, absolutely. All right, our next drug is
Iqirvo.
Yeah. Elafibranor.
Iqirvo. All right, like Seveso.
Yeah. So this is a dual peroxisome activated receptor alpha delta agonist used for treatment of patients with primary biliary cholangitis, which, as you would guess from the name, is a disease that affects the biliary system and the liver. And this is an autoimmune disorder, and this is a new drug that is used for treatment of primary biliary cholangitis. in combination with some other drugs in adults, again, who don't respond to the standard drugs alone. Or if they can't tolerate those drugs, then it can be used as monotherapy. But this is primary biliary cholangitis is a rare progressive autoimmune cholestatic liver disease. It causes a buildup of bile and toxins in the liver or in the bile ducts, known as cholestasis. And this leads to chronic irritation of the liver, which eventually will lead to liver failure, and the patient will become jaundice, itchy, all kinds of different signs of liver failure, and eventually can, end up in being fatal for the patients.
Mm-hmm.
And so this is a once a day tablet, which has a lot of
side effects.
A lot of side effects that most drugs that we talk about have. Yeah. All right.
And note that they said the side effects are more than 5% on all the patients.
Yeah. Yeah. So primary biliary cholangitis is on the right. So it's only affecting the intrahepatic ducts. So those are the bile ducts within the liver. Yep. There's also primary sclerosing cholangitis that affects both the intrahepatic and the extrahepatic bile ducts. So both basically come to the same end: severe liver damage, liver failure, and possibly fatal liver failure. So this is basically how it works.
Stages out right there. Yeah.
Mm-hmm. There's immune response to basically the patients attacking their own bile ducts. So it's again an autoimmune, and this causes inflammation of the bile ducts. Can lead to cholestasis or stasis of the bile within the bile ducts, and a buildup to a toxic level within the bile ducts in the liver. This then leads to fibrosis and then eventually end-stage liver disease and cirrhosis, and again can lead to the patient's final demise. All right, next.
Is it Vigafyde?
Sounds good to me. Vigafyde.
Vigafyde?
Yeah.
And it's a ready-to-use oral solution that's of the approved anti-seizure medicine Vigabatrin, which is used for the treatment of infantile spasms.
Yeah. Which is a rare form of epilepsy.
Yeah. But I mean, it's typically, Jay, we look at patients from 1 month to 2 years of age, and where the benefits outweigh the potential risk of vision loss for these patients.
Yeah. Yeah. Vision loss, hearing loss, chronic seizures, developmental delays
these
or
all
issues.
can be long-term and permanent as well, too, Jay. That's the thing about it. And it typically begins in children less than 1 year of age.
Yeah. And we'll talk about the different the symptoms and what to look out for that differentiates basically this issue this problem from regular old colic. So it works by treating the infantile spasms by inhibiting GABA transaminase, and so it's a neuromodulator in the brain. Of course, that when the levels are low, can lead to the seizures. But it, as John said, this is a drug that has a lot of potential toxicity. But in this case, the benefits of the drug definitely outweigh the risks.
Yes.
And so this is a little mnemonic from the infantile spasms group. Stop and see the signs. Clusters of sudden repeated uncontrolled movements like head bobs or body crunching. Take a video. They tell parents to take videos so they can show it to the patient's, their child's pediatrician. And then, of course, the way that it's diagnosed, is with an EEG, and then, of course, treatment to avoid developmental delays. And so On the left, you see the signs of the spasms: raising of the arms that may, and bending of the neck forward, crunching of the legs in midsection. And this, these little spasms just last a second or so, but they repeat every 5 to 15 seconds and go on for several minutes, as opposed to like a startle reflux or colic or gastric reflux, which will occur momentarily, and that's it. So this is a recurrent problem, and so for parents of children under 1 year old, these signs of the infantile spasms should be a cause for alarm and further diagnosis.
This is an interesting drug here, Jay, Sofdra.
Mm-hmm.
So sofpironium.
Mm-hmm.
And it's a topical anticholinergic indicated for the treatment of hyperhidrosis in adults and patients 9 years of age and older.
Yeah.
So bottom line, sweaty armpits. That's
sweaty armpits and sweaty palms.
Sweaty palms. That is correct.
Palmar hyperhidrosis. And so this is obviously characterized by increased abnormal underarm sweating that is beyond what's needed to regulate the body temperature. And for patients who have this is a serious condition. Even though you think, it's just they're sweating a lot, but it can affect social interactions. It can affect them at work. It can affect basically activities of daily living.
Yes.
And so there are surgeries that are done to treat this.
And also Botox as well.
And Botox, but that wears off over time. Yeah. So this is a drug that is given, I think, on a daily basis, or
once a day at night.
Once a day, that will reduce the hyperhidrosis. So again, this is an autonomic nervous system disorder.
Sweat glands.
Yep. So overactive sweat glands, and results in hyperhidrosis, excessive sweating, especially in the armpits and on the palms, but other places as well. I thought there was a. Okay, I'm thinking of a different slide. Okay.
There may have been a slide showing.
No, I'm thinking of a different one. Thinking of one coming up.
Yeah.
Okay. Thinking of for this one. All right. So the next one is
Ohtuvare.
And it's phentrine, which is a selective dual inhibitor of the enzymes phosphodiesterase 3 and 4, indicated for the maintenance treatment of chronic obstructive pulmonary disease, COPD, in adult patients. And of course, COPD is both chronic bronchitis and emphysema. And there are diseases that cause reduction in airflow by different mechanisms that are related most of the time to either working in an environment with polluted air, or most commonly cigarette smoking. And they're actually seeing a little bit developing with patients who are chronic cannabis smokers too, that, thinking it's safe, and it turns out that it's not. You're still breathing in all kinds of things that are harmful to the lungs. So this drug was fast-tracked because it seemed to be working quite well. And some of the side effects are paradoxical bronchospasm and an increase in psychiatric adverse reactions, especially suicidality, which is interesting. Let's see. I think we had. Okay, so it's both a bronchodilator and a non-steroidal anti-inflammatory. So it's interesting that the side effects would be bronchospasm and other, and psychological, psychiatric adverse effects. So this is COPD in a nutshell. Basically, the typical symptoms are, chronic cough, fatigue, chest discomfort, production of mucus, especially in chronic bronchitis, which leads to shortness of breath and dyspnea. In bronchitis, it's more a problem of inflammation and excess mucus in the airways, where in emphysema, there, you don't have the mucus production, but what happens is the walls between the alveolar sacs breaks down. And so the patients, obviously, they have difficulty not with inspiration, but with expiration because they don't have the elastic recoil in their alveolar sacs of a normal patient. So you can see here a normal bronchiole on the left, and on the right, a bronchiole that's been affected by emphysema. So bronchioles are narrowed and blocked with mucus in chronic bronchitis, and emphysema mostly alveolar sac destruction. And the symptoms can be, very mild to very severe. You probably will have patients coming into your office that have mild or even moderate COPD. Many of them, may need to be sedated or want to be sedated for their dental treatment. And so you've got to be well aware. And one of the big things with COPD is that the patient's respiratory drive is not related to low oxygen levels, but it's related to building up of CO2. So you have to be really careful when you give these patients oxygen that you don't suppress their respiration. So this is kind of what the difference between the patients are. So chronic bronchitis, patients overweight and usually cyanotic, their color doesn't look good. They've got an elevated hemoglobin because they're not transporting enough oxygen to the cells, and so the bone marrow responds by increasing the amount of hemoglobin. And so you may see hematocrits or hemoglobins in the 40s or higher in patients with chronic bronchitis. And of course, they're edematous and they're coughing and wheezing. They're what we call in medicine blue bloaters. Yeah. As opposed to the emphysemic patient who is a pink puffer. And this is a patient usually older and thinner. They usually have severe dyspnea. A lot of these folks are put on low flow oxygen. And if you listen to their chest, you don't really hear a lot of air movement because their lungs are essentially hyperinflated because of the damage to the alveolar sacs. Anything you want to add?
No, I mean, you just nailed all of that. I mean, because we've all been taught that. And hopefully, when we learned about our medically compromised patients, whether it be chronic bronchitis, the blue bloater, or emphysema, the pink puffer, how you can differentiate the two and the significance of treating these patients, Jay, in your office as well, too.
Exactly. We're through all the drugs. June was a light month.
June was a light month.
So
there we are already talking about breathing situations. So this leads us to our medical emergency. And so let's just say you're treating somebody, then all of a sudden they have a difficult time breathing, and then they start wheezing, and this can happen, all right, because this is a common disorder with many patients that come to our office. And so, what is happening in your dental office?
The patient's having an asthmatic attack.
Wow.
Yeah.
Okay.
And of course, you can differentiate this from an anaphylactic reaction, which would have similar symptoms because you won't see the swelling in the patient's face, the hives, etc., and the drop in blood pressure. This is just a struggle to breathe. And as opposed to emphysema, where you have destruction of the alveolar sacs and the patients have difficulty exhaling, with asthma, the patients have difficulty inhaling. It's a lot of extra work. So of course, what you're going to do, you're going to stop what you're doing and position the patient in the most comfortable position. It may be sitting upright for them. It may be reclined a little bit. And of course, most patients will come to you with a history of asthma. It's very rare that it just develops de novo that severe in an older patient. They may start with just like a mild cough or something like that, or a little bit of wheezing, but nothing too severe. So full-blown asthmatic attack is generally going to be in a patient who already has asthma diagnosed, which, of course, you should know from your in-depth medical history that you've taken. And when we talk about asthma, I always go back to the old adage, you know, you ask a Jewish person a question and they answer with more questions. So it's same. The patient says they have asthma. Well, what do you want to know? You want to know how bad is their asthma?
Yeah. When was the last attack?
When was the last attack?
What were you doing when that attack occurred?
What drugs, what are you taking for your asthma? Is it just a PRN inhaler, or is it steroids, or a preventative drug? Have they had to go to the ER because of their asthma? Have they ever had to be intubated because of their asthma? All those things are really important to know. And for the most part, these patients will carry their own inhaler of albuterol. Yeah. But of course, you want to have this in your office emergency kit in case the patient did not bring it with them.
Yes.
Yeah. So usually a couple puffs from the inhaler will get rid of it, get rid of the asthmatic symptoms. You may have to repeat it a second time. And of course, you're going to look at the patient's vital signs.
That's right.
And if it looks like they are, after the first couple puffs, they're not doing better, of course, you want to call 911 because this could deteriorate into a very severe situation. And the thing to remember with patients who are having asthma attacks and having trouble breathing is they will be tachypnic at first because they're trying to get as much air in as they can. You'll start seeing them using accessory muscles of respiration. What will happen eventually is they're going to tire out. Their O2 sat's going to drop, and then you've got a true medical emergency on your hands. You never want to let it go that far.
Yeah, the wheezing is going to pick up, and wheezing is not a good sign in an asthmatic patient.
No. So again, what's going on in an asthma attack is a couple different things. One is production of a thick mucus, which makes it hard to breathe, but also the smooth muscle layer contracts. Normally it's relaxed, and what it does is it obstructs the airway. So you got two things going on, and generally albuterol is what you need. If it's not working, another option as a backup would be epinephrine.
Well, it typically means this asthmatic attack is refractory to your albuterol, and you're going to have to give this patient some epinephrine. And hopefully you've already called 911 during all of this. Yeah. Okay. And Jay, something I just want to stress to everybody, you brought it up, the medical history, when do you have your asthmatic attack? Is it due to stress? Mm-hmm. And think about where they are. They're in the dental office. Yeah. And we've already talked about our IV sedation course. I say over half of America is afraid of the dental office. Yeah. Okay. And one thing you can do to help yourself before you treat this patient, have them take a couple of puffs of their inhaler. Mm-hmm. You may never experience an asthmatic attack in your office. I know Jay and I, before we treat any of these patients, before they're brought back,
2 puffs of the inhaler.
2 puffs. Our staff sees them take 2 puffs of their inhaler right then. Mm-hmm. I've never had an asthmatic attack.
Me neither, so far. Okay. Is there some wood somewhere? And of course, the location is in the lower airway. Yep. With asthma. But you may need to differentiate that if patient aspirates, if you're not using airway protection, the patient aspirates, that can cause laryngospasm and wheezing and difficulty breathing.
That's right.
So that's why we always protect the airway whenever we're doing surgery, and you should do it for really whatever you do in dentistry. And then pulmonary edema, that's usually going to come on slowly, but also something to keep in mind. That's a lower airway problem. As far as our shameless plugs, we've got our PharmaDent series through Dental Learning, only $99, and it's 24 different categories. No, am I getting 15. Everything confused? 15 categories of all, not the medications we cover in this webcast, but kind of the basics, because you forget them all. If you don't see them every day and remember what they're for, this is a great review that you can go back and look at as
Anytime.
many times as you want for only $99. Then we've got
There's
our
your 24 right there.
Yeah, there's the 24. The four modules of medical emergency simulations, where we basically go through 24 different medical emergencies, and we look at all the algorithms one by one, and have a lot of background information to help you understand and diagnose what's going on. And then, of course, our IV sedation course at Vesper Institute.
Jay, I want to say something else about that too as well.
Yeah.
There's many of you out there listening to us on a monthly basis. You may have already taken an IV sedation program somewhere else, but let's say you never finish your clinicals. Or maybe you just took the first part of it and you just weren't happy. I encourage you to look at us, and we're going to be that course that makes you happy. Like Jay said earlier in there, when you get to our phase 3, which is clinicals, you're going to be working one-on-one, hand in hand with another IV sedation certified general dentist.
Yeah.
They're going to be doing what you do every single day in your office.
Yeah, and they're not nearly as intimidating as me and John.
And why would you not want to choose this program anyway? Just the simple fact of that. So I encourage those of you that never finished from another program, check us out.
And we've seen a number of students, same exact situation. They took IV sedation course, 9 years ago, and just never got around to getting their permit because they didn't know what supplies they needed to order. They didn't know how to set up their office. They didn't know how to teach their staff. And that's another thing that we didn't mention is we actually have a module. We encourage you to bring your assistants with you, but we also have some dental assistant, IV sedation assistant specific modules that are led by IV sedation trained dental assistants, which is great. So then when you get back to your office, everybody's really excited to implement this, and we give you all the tools to be able to do it. And then, John, you've got your pediatric sedation and airway emergencies, also on dental learning. And I guess that is about it for this month. Not too many drugs. So we'll see you back on August 9th, about a month from now, and we'll have all the new drugs that were approved by the FDA in the month of July. And of course, a new medical emergency of the month that we'll talk about, and you'll learn all kinds of good things. So,
thank you for being here.
Yeah, thanks for being with us, and we will see you next month.
Absolutely. Take care.
Let's see if I can find... There we go.